Thank you guys all for inviting me out to talk today. As Bill said, I've trained to do structural cardiology, so working on a lot of heart valves and heart valve disease is my specialty within the field of cardiology, which can be quite broad. Today, our focus will be on the mitral valve. It's one of the 4 heart valves. It's the one that we're most rapidly changing therapies and involving our treatment algorithms going forward. So without further ado, we're gonna get this started. There we go. I don't have any disclosures for this talk. One of the important things when you're talking about the heart is understanding the different chambers in the heart and the function of the heart. So this is just an overview of what a normal heart looks like in an individual. There are technically 4 chambers, the 2 atriums that are on the top and the 2 ventricles on the bottom that end up being the pumping chambers. The mitral valve happens to be between the left atrium and the left ventricle, and it controls blood flow. So it's in a unidirectional from the atrium down to the ventricle and out to the body. Now, in a handful of people, this mitral valve can become dysfunctional. If the valve becomes dysfunctional, it can lead 2 things. One, it does not open fully, causing blood not to go into the ventricle. That is called mitral valve stenosis. The focus of this talk will be more on the other pathology. If the valve doesn't work well, and then it ends up causing blood flow to leak back into the heart. So rather than going in this direction from the atrium into the ventricle out to the heart, the blood goes from the atrium into the ventricle and then squirts back into the atrium. So that would result in inefficiency within the heart. So every heartbeat, some of the blood goes forward where it should, some of the blood ends up staying within the heart. Over time, you can see how this could be a problem. If the blood's not pumping out of the heart because the valve isn't coming together entirely, then over time, the heart can start struggling. As with any pump, if you overload it, it starts failing. So understanding the anatomy of the heart kind of makes a big goal in understanding how we best treat this. As I said, today we're going to focus our talk on this specific pathology of the mitral valve in the handful of people who have mitral valve regurgitation, or it's also known as mitral valve insufficiency, where blood, rather than going forward into the body, comes back and recirculates within the heart because of usually poor coaptation or the valve just doesn't come together entirely. So mitral valve regurgitation is prevalent and it's growing. A few years ago, there was probably about 2.5 million Americans with mitral valve regurgitation. It's projected to nearly double in the next 7 or 8 years, up to 5 million individuals. So it's going to be more common as long as people live longer. Mitral valve disease will become more prevalent. It's just sometimes a wear and tear phenomenon. Just with any mechanical part, it can wear itself out. Now, though mitral valve disease is prevalent, it's also one of the more under-referred, under-recognized disease modalities. Nowadays, aortic valve disease has really taken off with the advent of minimally invasive aortic valve replacements, or what are known as TAVRs. These are recognized fairly quickly and oftentimes are referred very often. So here at Eisenhower alone, we do about 200 aortic valve replacements minimally invasively a year, and that's only growing. Our mitral valve program is about a quarter of that at this time. We do about 50 to 60 mitral valve repairs using the minimally invasive approach at this time per year. With that said, though, if you look at the all-cause numbers, the actual prevalence or the amount of mitral valve disease is significantly higher than the amount of aortic valve disease in the community. Yet we are doing a lot more aortic valve replacements than we are doing mitral valve interventions, only because oftentimes it's under-recognized or under-referred to a structural cardiologist who can offer treatments. Now, mitral valve regurgitation is deadly in a lot of ways. It's not acute. People don't usually drop dead from mitral valve regurgitation, but as you can imagine, if the heart's not able to pump efficiently, what happens is you start by having the mitral valve regurgitation, which then causes increased load or increased fluid to retain in the heart. As that fluid stays in the heart, the muscles of the heart start dilating, stretching, they start becoming damaged. As they become damaged, then the heart function starts decreasing and the heart starts getting weaker. As the heart gets weaker, it starts ballooning. Now, as the heart balloons, the valves are attached to the side of the heart. So if the heart's getting bigger, now the valve gets pulled apart even further. As the valve's getting pulled apart even further, you start getting more mitral valve regurgitation. And then this cycle just continues over and over again until people develop congestive heart failure and other complications from it. So recognizing it early oftentimes is one of the key in treating this so that you can prevent the heart from getting weaker, the heart from getting bigger, because once that happens, then it gets a little more challenging to treat. Not impossible, but a little more challenging. So what are the symptoms of mitral valve disease? Again, as I said, it oftentimes gets overlooked or missed because a lot of the symptoms overlap with a lot of other cardiac conditions. In particular, the most common ones you'll see are shortness of breath. Now, shortness of breath can be caused by a lot of different things. It can be caused from any slew of cardiac conditions, can be due to lung conditions as well. But that's usually the most common symptoms. Fatigue, again, there's a wide range of causes for fatigue, but oftentimes if you start seeing a constellation of all of these symptoms, you start wondering. Swollen feet or ankles. Probably a handful of people who've had this in this room alone. Now, not always is swollen feet or ankles associated with valvular heart disease, but it can be. So when we start looking for these signs, shortness of breath, fatigue, swollen ankles, inability to exercise. So slow progressive decline in exercise capacity can be a sign of valvular heart disease as well. Now, again, a lot of times people attribute this to just getting older or find excuses, but it can be a subtle sign that something is changing. Now, other symptoms, when it gets severe enough, you can get decrease in appetite, fainting, you can start developing a cough. Usually it's a dry cough, not usually productive, but you can develop a cough just from fluid building up within the lungs as well. So if you're having these symptoms, it's worth talking to your primary or talking to your cardiologist, making sure they've just taken a look at your valves, making sure they're okay. Now, a lot of these symptoms can correlate with not just mitral valve disease, any valve disease can present this way. But if you're having these constellation of symptoms, definitely worthwhile talking and mentioning these to your doctor so they can do the appropriate screening test. These are very non-specific, very generic, and it's because of that that sometimes it's not clear-cut who has mitral valve disease, who does not. Now, the MitraClip procedure, that's what we're going to talk and spend the bulk of the procedure or bulk of this talk discussing. This is a procedure we do right here at Eisenhower where we can repair the mitral valve without having to undergo open heart surgery. Now, classically, the way to treat valvular heart disease has been open heart surgery. That involves cutting open the chest, oftentimes cutting into the heart, and either replacing the valve or trying to repair the valve with sutures, stitches, or valve replacements. Now, the MitraClip is a new alternative treatment. It's been around now for almost 2 decades, but really commercially available in the last 10 years or so, where it's a minimally invasive procedure where you can perform the entire procedure through a small puncture in the leg. It's done with the heart beating. There's no need for being placed on bypass. And it also lets us get real-time feedback as we're doing the procedure to identify how effective we are with the treatment. Now, the benefits of the MitraClip, again, minimally invasive, and we have shown, and I'll go over some of the data, that we do get very good results in reduction of mitral valve regurgitation. The clips look like these little clothespins. Normally they're open in this wide open V, but they can close or open depending on how we manipulate the device. This is a dime, so they're actually quite small, these clips. They're smaller than the size of a dime. They come in 4 different sizes. You can see 2 of them here. One is a small clip, one is a larger clip, and there's a narrow clip and a wider clip. We select the clip based on the patient's anatomy and what we think would fit best to reduce the leak. Now, this is a video playing what exactly the procedure entails from start to finish. So we'll kind of go through each of the steps. We're on the 4th generation of the clip. That's why it's called the G4. What we end up doing is we access the femoral vein through the leg. And from there, we advance a little wire all the way into the heart, through the right side of the heart. And we make a small puncture in the heart to get from the right side of the heart to the left side of the heart where the mitral valve is located. So again, it's accessed through a vein in the leg. And then we introduce a catheter over that wire into the small hole we made inside the heart. Through this catheter, we position it in the left atrium. We're now right above the mitral valve. All of this is done with an echocardiogram guiding us and x-rays guiding us. So again, all of this through a small pinhole size of a pinky puncture in the leg. From there, we identify where the leak is the worst on the mitral valve, and we position the valve. We check to make sure the valve is functioning well before we even go under, that it closes. Then once under, the point of the valve is that the clip is to bring the leaflets together to reduce the amount of leak. So once the leaflets lay in, we secure them in place with what are called grippers, and then we tighten, make sure we have enough tissue in there. Once the grippers are really secured in there, we check to make sure everything is working well, and then we tighten up the clip, sealing together the leaflets, pulling them together. and essentially doing what's equivalent to what's called an Alfari stitch, which is a surgical technique for mitral valve repair. Once everything's done, the clip gets deployed and we take the device out of the body. You can see the leak back here, no leak right here. When you have an appropriately deployed clip, that's what we expect to see, is resolution of the blood flow backwards. Now you can place as many as 1 clip up to 4 or 5 clips, just depending on how big the valve is. The main limitation is you got to make sure enough blood is still going forward through the heart. If you put too many in, you can zipper the valve closed, and then all of a sudden you've taken care of the leak. There won't be any more leak, but there won't be any blood forward either. So it's a fine balance between how many you can put in, and it just depends on the person and depends on how much the leak is. Now, there's 2 types of mitral valve regurgitation when we talk about it. One type is called primary or degenerative mitral valve regurgitation. This is usually, if you've heard of mitral valve prolapse or other diagnoses you may have heard of, this is when your body has a dysfunctional valve. The valve itself is damaged in one way or another. A lot of times these are congenital abnormalities more than acquired abnormalities, but the valve itself isn't functioning well. Now, these type of valve disease really do need repair, whether surgically or through minimally invasive approaches. And the only way to fix these is through a mitral valve repair, whether surgery or the MitraClip. There's a second type of mitral valve regurgitation called secondary mitral valve regurgitation. Now, secondary mitral valve regurgitation is different. As I talked about before, the valve is attached to the side of the heart. Now, if the heart itself were to start enlarging, the valve starts getting pulled apart. The valve can't grow, it's a limited length. Now, if the heart starts getting bigger and say this wall starts moving outwards, the valve will come with it. And all of a sudden, now you're left with a gap in between the leaflets, and you're going to get mitral valve regurgitation. There's nothing physically wrong with the valve itself. The problem is the heart got so big that it's pulled the valve apart. Now, primary mitral valve regurgitation, I said there is something wrong with the valve itself. That's why the leak is occurring in the first place. What happens, though, is if you leave primary mitral valve regurgitation alone long enough, as we talked about before in that circle, the load starts increasing, the volume starts increasing in the heart, and the heart starts stretching. So oftentimes primary mitral valve regurgitation can develop into a combination of both primary and secondary mitral valve regurgitation, because as the heart weakens and balloons, the valve will separate and then you'll increase your leak. So we differentiate between these two because there's different therapies that are offered for both. Now, for primary degenerative mitral valve regurgitation, there's 2 options for repair. One is either open heart surgery, or 2 is a MitraClip. Now, based on the approval criteria for the MitraClip, again, it's been out about 10 years or so, but open heart surgery has been around for 40 years. So we compare the results of the MitraClip to open heart surgery. And for now, the FDA approves for primary mitral valve regurgitation treatment with minimally invasive approaches such as a MitraClip only in people who are turned down for surgery, who are considered very high risk or prohibitive risk for surgery. And the reason for that is the data just isn't strong enough yet to say, hey, the MitraClip works just as well as open heart surgery. It's coming, and there are trials ongoing right now. In the future, this may change. But right now, the FDA and Medicare only approve the MitraClip for people who are deemed very high risk for open heart surgery. So anytime you get evaluated for one of these procedures, an open heart surgeon is part of the team that evaluates you. And they usually will comment, are you high risk, low risk, or even prohibitive risk for surgery? So what makes you high risk for surgery? A lot of times there's a lot of variables that go into it. Some things can be as simple as frailty. If the surgeon doesn't think you'll be able to rehab well afterwards. If there's memory impairment, that could qualify as a reason to get considered high risk for open heart surgery. But that comes as a heart team assessment. The surgeon, ourselves, the general cardiologist, oftentimes we'll all put our heads together and make recommendation. Do we think someone's high risk, low risk, intermediate risk? Now, if you're high risk and turned down for surgery, then the MitraClip would be an option for this. The other indication is you have to have symptoms. Having mitral valve disease alone does not need an intervention at this time. Again, the thought is if you're not having symptoms, your heart hasn't dilated or changed as much. But if you're not having symptoms and you have mitral valve disease, you still need to be monitored quite carefully. Every few months to a year, you'll see your cardiologist. They'll do echocardiograms serially, making sure your heart's not getting weaker, making sure you're not developing symptoms. Now, If you have symptoms, then we're a lot more aggressive in treating valvular heart disease. If you're asymptomatic, a lot of times monitoring is the course of action, unless we see that your heart is getting weaker, or unless we see that your heart is starting to stretch, because then we want to treat it before that happens. Now, that's for primary mitral valve regurgitation, when the valve itself is dysfunctional. When you have secondary mitral valve regurgitation, that's when the heart itself has gotten so big that the valve is pulled apart. We know based on the data that open heart surgery does not bode well for individuals with secondary mitral valve regurgitation. They've studied this, and people actually did poorer if they went to open heart surgery to try to reconstrain or put a ring around the valve to try to bring it back together. So the only proven therapy that's shown efficacy and improvement quality of life for secondary mitral valve regurgitation is the minimally invasive approach, the MitraClip. So if you're having secondary or your valve is okay, but the heart is a little bit bigger, then it's a much more straightforward approach to going through the minimally invasive approach to getting the valve repaired. Now, who can't get a MitraClip? Again, if you can't tolerate blood thinners, we can't do the procedure, because during the procedure, we give some blood thinners to make sure no blood clots form on the device. You minimize your risk of stroke. So if you're actively bleeding or having a lot of blood loss, we can't necessarily do the procedure until that gets addressed. Now, if you have an allergy to technically nickel, cobalt, chromium, then that would be an issue as well. That's very rare. If you have an infection on your heart, we can't implant any foreign material in an actively infected heart. So if you have an infection causing mitral valve disease, or if there's a bacteria on the valve that's actually destroying the valve, the only treatment then is open heart surgery. The surgeon would have to cut out the infection and clean it out with antibiotics and put a new device or new valve in. Now, rheumatic mitral heart disease, it's congenital or it's an acquired defect. As of now, it's an off-label use for rheumatic mitral valve disease, and it's not necessarily recommended because, again, the pathology of the leaflets, sometimes you're at a higher risk that the clip itself can damage the valve when you're trying to clip it, that you can rip the valve with the clip. Now, as I said, the MitraClip has been around for about 18 years or longer from clinical data. But it's really only hit the market about 10 years ago. The trial started about 8 years before then. And over time, we've done quite a bit of studies and continue to do studies on the MitraClip and watching it advance through all these clinical trials. Now, as of 2020, the AHA and ACC, those are the big two cardiology groups in America, have approved the MitraClip as we call a class 2A indication, which is a class 1 is everyone should get it. A class 2A is a very good record. It's right below a class 1 indication. A class 3 indication is something we should not do. But as we get more and more data, we can see that, hey, it's been moved up from a 2B to a 2A, and we're going to see if it'll ever get to a class 1 indication. But there are very few class 1 indications in cardiology. Now, as we get better with the clip, so is our procedural success rate. Now, our implant rate is about 99%. What does that mean? If you're getting to the table, you're doing the procedure, 99% of the time, we're able to place a clip. There's a 1% time we go in, we think we can place a clip, but we aren't able to place the clip. What happens is maybe we put the clip in and all of a sudden we take care of the leak entirely, but then no blood is going forward. That's happened once or twice. We've taken care of the leak, but if the valve is very small, sometimes the clip is just too big. And we can find that out sometimes during the procedure. Other times we go in and we notice the valve, just the anatomy doesn't look favorable. A lot of times we'll screen this out. So it's very rare that that happens once you get to the procedure date. But our success rate is very high. Now, the acute procedural success rate is about 96%. The procedure time is about 80 minutes. That's if you're placing one or two clips. It can be longer depending on how many clips get placed. And I said up to 5 clips have been placed at a time. Typically, per each clip, it takes about 45 minutes. The fastest we've probably done one of these procedures is about 45 minutes, start to finish. Now, the procedure is done under general anesthesia, mainly because during the procedure, there is a camera down your throat. And that's the most uncomfortable part of the procedure. The actual access in the leg is no more than an IV poke. Typically, after the procedure, people stay in the hospital on average 1 to 2 days. We're actually closer to 1 day. The national average is about 2 days. 90% of people have significant reduction in their mitral valve regurgitation. We grade mitral valve regurgitation as 4+ being severe, 1+ being mild. 0 being no mitral valve regurgitation. Now, when you place a clip, we consider it a success if you drop by at least 50%. But a lot of 90% of people who started with 3+, 4+ mitral valve regurgitation have a less than 1+ mitral valve regurgitation after the procedure. And that typically holds up also after about a year. Now, sometimes 10% of people, the clip works, but again, you can develop some recurrence of leak around the clip, and that can happen. More often than not, even when that happens and the leak comes back, the symptomatic improvement persists. We use what's called an NYHA class to describe how functional someone is. When someone is NYHA class 1, they can function, go to meetings, walk around, do everything. When they're class 4, they can't walk to the bathroom without being winded. So typically with the MitraClip, we see a lot of people be in class 1 or class 2 right at the end of the procedure, and typically, again, that lasts durable for years. Now, what's most impressive is the number needed to treat to prevent 1 death in people who have heart failure and mitral valve disease is about 8. So that's, if you treat 8 people with the MitraClip, you prevent 1 death. And we'll compare that to what other data shows for other medications, but it's one of the more effective treatments we have in preventing death and heart failure nowadays. Now, the amount of reduction we get in mitral valve regurgitation, again, with a 99% procedure success rate, these are the newest trial data. If you started off with the dark blue being 3+ MR, the red being 4+ MR, almost, let's say, 68% of people had what we consider moderate to severe mitral valve regurgitation. By the end of the procedure, and at 30 days, no one had severe mitral valve regurgitation. Only 3% had moderate, and 90% of people had mild or less mitral valve regurgitation. Now, I'll be honest, to do the MitraClip to get rid of the regurgitation entirely sometimes can be challenging, because when you place a clip on the leaflets, it can sometimes leak around the clip on both sides of it. Now, in a handful of people, you get no MR, but most of the time you're left with some MR, and that's why we consider a procedural success less than a 50% reduction. It's one of the advantages that the surgeons have, and it's why for the primary mitral valve disease, if you do go to surgery, the surgeon should aim to always have no mitral valve regurgitation, because they're in there, they can repair it and replace the valve entirely. So that's why right now the MitraClip has still been approved only for people who are considered high or prohibitive risk for surgery, because based on, though we're getting better at it, you still get left with some mitral valve regurgitation sometimes after the MitraClip, whereas with surgery, you could be left with no mitral valve regurgitation. Now, yeah, the procedure success rate is improving, the significant reduction, we keep getting better at it every single time. The quality of life improvement, there's this thing called the Kansas City questionnaire that looks at quality of life. An improvement of 8 points is considered a significant improvement. Now, people have a baseline score of 47. The higher one score is, the more functional, the more adept they are at life. If you go from 47 after the MitraClip, you go up to almost 67, 70, and it continues to get better. As people do cardiac rehab, as people get stronger after the procedure, their quality of life continues to improve up to a year. As I said, if you went up 8 points from 47 to 55, that would be considered a great improvement. Going from 47 to 70 is the difference between not being able to walk from the parking lot to the clinic to all of a sudden being able to go to the gym and walk on the treadmill. So it's a pretty significant improvement in the quality of life that you can see with the clip. Now, not only is it immediate or within 30 days, but as people do the cardiac rehab, everything, it's sustained out for a year or so. Again, the NYHA class goes from class 3 or 4, almost 70% of people, down to 1 or 2, almost 80% of people with the intervention. The actual safety profile of the procedure is actually really quite safe. The risk of any serious complication from the procedure is less than 3.1%. So it's almost a 97% kind of procedure, or 97% of the time we do the procedure, there really is no adverse event from the procedure itself. The risk of all-cause mortality in people who underwent the MitraClip may seem a little high at 15%, but this isn't from the procedure itself. Procedural-related mortality is less than 0.3%. But the individuals who've been getting the MitraClips have been turned down for surgery. They're generally older. And if you look at the database, yeah, if you take a 90-year-old and you put a device in them, there's a good chance 10%, 15% of 90-year-olds will just pass at 1 year, regardless of the procedure. The risk of stroke from the procedure, less than 1%. The risk that we damage the heart leaflet, that's a tear in the leaflet, if we select our patient right, less than 0.4%. The need to go back in and do any other intervention, less than 2%. So very safe procedure, all things considered. Probably the biggest risk would be general anesthesia, and it's usually for about an hour or two that you'll be under. Now, as it's mentioned before, the only device we have to treat the secondary mitral valve regurgitation, the one that's caused by the heart getting enlarged, is the MitraClip right now. Surgery is not recommended at this time. And the number needed to treat, if we did medications alone, these are two curves, and this is all-cause mortality. The blue line is if we did medications alone. This bottom line, if we did medications and added a MitraClip therapy. You can see as time goes on, this is up to 3 years out, the curve starts separating. People who are on medications alone have a much higher mortality rate than people who get the clip early and also are on medications. You can reduce the relative risk and death by almost 1/3. And the number needed to treat, again, 8 is a pretty impressive number, because no matter what we do, we put a lot of people on medications when they have heart failure. Some of these medications, you need to treat 43 people with the newest medication called Farxiga to reduce 1 death. Entresto gets advertised on TV a lot. You need to treat 36 people with Entresto in order to prevent 1 death. If you put in a specialized pacemaker to treat heart failure, you need to treat 10 people to get it. So with the MitraClip, at 3 years, if you treated 8 people with the MitraClip, you can reduce 1 death. More importantly, not just death alone, the MitraClip reduces rates of hospitalization. Now, death is great. We want to definitely reduce people from dying, but we also want to make sure your quality of life is good, that you're not spending every other week in the hospital needing to get medications. The number needed to treat to prevent a hospitalization is 3 people. So if we treat 3 people who have heart failure and have mitral valve regurgitation, we can prevent a hospitalization. For every 3 people, you can prevent hospitalizations. And this is up to 3 years. So it's a 50% reduction in the rate of hospitalizations with this device. Now, the quality of life we talked about again, almost 2.5 times improvement in the generic kind of scale in quality of life. And it's almost immediate from when the clip goes in, and it sustains. People seem to continue to improve and maintain their improved quality of life. There's no significant decline that we notice after the clip goes in. And that's probably the most noticeable thing that patients notice, besides not being in the hospital. Now, this has been around, I said, for almost 18 years now. Over 150,000 patients have been treated. In the studies alone, 80,000 people have been studied. So this has been a very well-studied device before it came out on the market. And again, the outcome data is outstanding. There's very few things that help people keep out of the hospital and stay alive compared to the MitraClip. 97% of people are free from any type of complication from the procedure. So it's considered a safe, durable, and effective treatment to treat mitral valve regurgitation right now. And the only treatment we have for the secondary mitral valve regurgitation, and an option for those with primary mitral valve regurgitation who are deemed high risk for surgery. So this is where I kind of open it up to questions that you guys may have. Yes.
So I want to ask you, I think I'm good. Early.
It's on.
It's
on, Bill.
2B recommendation. It's actually a 2A recommendation.
Yeah, it's moved up from 2B to 2A for a second.
Explain that.
So as we get more and more data from the trials that are ongoing, we're realizing, hey, it's a safe and effective device. So as the guidelines or as the big groups meet, the ACC, the AHA, they meet in groups every few years and they make recommendations based on the data on what available treatments are. As more data gets published, more data gets reviewed, they'll either move the therapy into a more favorable or less favorable approach. And over time, with how safe and effective it is, they're moving it closer to a class 1 indication. So 2A is it's better than a 2B. Yeah. So it's moving in the direction towards a class 1. Again, as I said, very few indications. There are very few indications for class 1 repair. Yes.
While we do that, we have a question on the chat. It says, I had a friend who had open heart surgery several years ago. The doctors put a porcine valve in her. Was that a MitraClip?
So a porcine valve done under open heart surgery is a mitral valve replacement. So in that procedure, what the surgeons did was actually cut out the native valve and place in a bioprosthetic valve. Now, if you have a bioprosthetic valve put in, typically I have not seen anyone put clips on a bioprosthetic valve. What happens is once you have artificial tissue, whether that's a porcine, which is a pig valve, or a cow valve, those valves do have a lifespan, about 8 to 15 years before they may start degenerating or breaking down. If they do break down, as I said, the MitraClip may not be the best or viable option, but there are other mitral valve therapies out that can be done minimally invasively, where you can replace a valve through a puncture in the leg. And it's called a transcatheter mitral valve replacement rather than a repair.
Great. Go ahead, Bill.
What would you say is the likelihood of a person such as myself who has had a mitral valve repair to be or to be needing in the future a mitral clip to replace or whatever?
So that's a very good question. Now, the question is, for people who've had mitral valve repair, what is their prognosis? Typically, mitral valve repairs, if they're done well, can last a lifetime. And it's why if someone is young and has mitral valve prolapse or has this primary mitral valve disease, and the surgeon can repair the valve, we recommend going to open heart surgery and having a mitral valve repair performed surgically. Now, again, if it is done well, that's a lifetime. That's no need to worry about it degenerating, falling apart. Oftentimes, though, it's dependent on the surgeon and the skill of the surgeon and how effective the repair is. So if a mitral valve repair has happened, it still needs to be monitored. But if it's been 20 years and the mitral valve repair is held up, there's a good chance that you may not need any future mitral valve intervention, barring some other change in your clinical picture, something that might damage the mitral valve otherwise. So it's one of the reasons why, yeah, if you're young, you're healthy, and you can have a valve repaired by a surgeon, the data suggests, hey, go get a mitral valve repair with open heart surgery, as opposed to doing a MitraClip where we have 18 years of data. But for a mitral valve repair, some people have had it for 30 years, 35 years, and never have to worry about having another intervention done.
Go ahead.
Yeah, just curious, one of your first slides indicated that the incidence of this might double by 2030.
Yeah.
What are some of the factors? Are there any factors besides just an aging population that go into that?
Yeah, so there's two factors. One, we're recognizing it more. As our echocardiograms and get better, we can pick up on mitral valve regurgitation a lot more effectively. So that's going to increase the number. It's always been there, but we're just recognizing it a lot more frequently. Two, mitral valve disease, especially secondary mitral valve disease, is a disease of the elderly. People who have other heart disease, comorbidities, their heart can weaken. As their heart weakens, it can stretch, and that'll lead to more mitral valve regurgitation. So as people live longer, as with any mechanical part, there's a risk for the part to fail. So as people are living longer and the average life expectancy of the Americans increasing, we expect to see more valve disease.
I'm not sure I need it. All right. The question is, Doctor, can the TAVR procedure and the mitral clip be done at the same time?
So they're done, the same person can have both procedures done. I'll say from a reimbursement standpoint, I don't know too many people who get both procedures done simultaneously, partially because they are two separate procedures that are done similarly but slightly differently. For the TAVR procedure, you put a large hole in an artery. For the MitraClip procedure, you put a large hole in a vein. So I have not seen that done regularly. They can be done in a staged fashion. You get one procedure followed by another a little bit later. That happens very commonly. More often than not, doing both at the same time. I think I've seen that happen once, and I can't remember the exact reason why it was done at the same time, but I think it had to do with the patient was leaving the country and was going to be gone. And it was done pro bono. Yeah, because no insurance will pay for both procedures to be done simultaneously. Now, if you go to open heart surgery, you can get both valves repaired simultaneously because, again, no one wants to get cut open twice. Yeah.
That pro bono stuff sounds like the work I do for my daughters. I don't know what that means. So anyway, are there more questions out here? Yes.
So the question really is, open heart surgery sounds so scary, et cetera, that the FDA and Medicare would rather you have open heart surgery than trying this clip. And it's really just because of data at this point?
It is data that proves it. And as you said, remember, open heart surgery is scary, but the data is there. It's been around for a long time. The results are very good. And I said, the surgeon will guarantee you no leak, no residual regurgitation. The MitraClip will guarantee a 50% reduction in your mitral valve regurgitation. So 50% reduction is enough to improve your quality of life, enough to keep you out of the hospital, make you feel better, but it's not a perfect result. Now, sometimes you do get a perfect result with the MitraClip. You just don't know that until you're in the middle of the procedure doing it. So the data is coming in time, that might change. The recommendations might get, hey, try the MitraClip. If it fails, go to open heart surgery. But right now, the data suggests, hey, if you have an option to get surgery, and especially if you can get a mitral valve repair from a competent surgeon, that'll last a lifetime. And the MitraClip's been around 18 years. But again, a lot of the initial people who had the MitraClip placed, fortunately, due to other comorbidities, they're not around. So we don't know the long-term durability of placing a MitraClip in a 45-year-old. We know in a 45-year-old who undergoes mitral valve surgical repair, that might be all they need the rest of their life.
And I hear there's robotic repair.
There are
That-
robotic
that's
surgical
Open
repairs.
heart surgery still?
So those are available, and depending on patient's anatomy, sometimes you can get minimally invasive robotic mitral valve repairs, and depends on the surgeon. And I know Dr. Sheeman over at UCLA does them and does them frequently. You want to go to a surgeon who does a fair amount of these. You don't want to go to someone who's just doing their first robotic surgery on this, because it is I've seen it where they go for these robotic repairs and the procedure looks good at the time, but the repair isn't as durable or holds up over time. And if you're going to get open heart surgery, you want it done right the first time and only time.
So that is replacing the valve.
It depends.
Robotically.
You can replace it robotic. Sometimes they can repair it robotically too, where they keep your valve. It just depends on your anatomy and what goes in. Sometimes you'll go in for a minimally invasive robotic repair and they find out they can't do it. And then you have to get opened up right then and there and get a normal classic valve replacement. That again comes down to the surgical skill of the surgeon. And it's really an exposure, how much exposure you can get at the time of the surgery.
So it might not be mitral valve repair, but how many people in here have had open heart surgery? But most of them are probably bypasses. Mostly bypasses, mostly a bypass surgery, open heart. You didn't have it, you had mitral valve. So there, we have that. And
Yeah.
I said I had mitral valve repair, but it was done robotically. So I can't necessarily say I had open heart surgery. I didn't. But I
Well,
did have the repair done robotically.
so you could technically say you had open heart surgery because they cut into your heart and they opened it, but you didn't have the sternotomy. Yeah.
They put me out for 3 hours the whole night.
Yeah, but you didn't have the sternotomy or the fracture. Yeah, yeah.
Another question here, Bill.
where is it?
Is there a variability in the quality of the porcine or other replacement valves?
There are, depending on, some of the older valves weren't as good as the newer valves. So I'll be honest, the valves continue to evolve and they get better over time. Now, is there a big difference between porcine or bovine valves? Not necessarily. What we know is porcine valves tend to fail with regurgitation, so they leak more at 10 or 15 years. Bovine valves tend to get more narrow. They tend to get constricted rather than leak, but they still have about the same kind of longevity. About, we expect 10 or 15 years from a surgical valve.
Is there a procedure at all or being studied that a TAVR valve can be put inside of a mitral valve?
So we do TAVR valves inside of mitral valve replacements currently. If you've had surgery, whether it's a mitral valve repair, mitral valve replacement, and you have the scaffolding or the availability of a prior surgical valve, you can fit a TAVR valve most often within the mitral valve. Now, there are ongoing trials right now looking to try to replace the mitral valve through a percutaneous approach. What does that mean? Rather than trying to put a clip and trying to bring the valve together, actually replace the entire valve entirely through a small puncture in your leg. Now, there are ongoing trials. I think the two major sites that are doing them are Cedars-Sinai and Scripps right now. They're purely investigational at this time. And we just don't know the long-term data or even the short-term kind of data with it because they haven't been published or released yet. Now, the people who typically qualify for those trials are usually turned down for surgery for whatever reason.
You mentioned that the TAVR and the MitraClip go in, one goes in an artery and one goes in through a vein.
Mhm.
Which is which?
Okay, the TAVR goes in through the artery to get to the aortic valve, and
Which artery?
it goes to
Which-
your femoral artery.
The femoral
Yeah,
artery.
typically, yes. And then the femoral vein is where the MitraClip goes into.
But they're both located in the same.
They're right next to each other
Oh.
in the leg. So they're within, they actually touch each other within the leg. So that's why it looks very similar and the approach is very similar, but the bleeding risk from an arterial puncture is much higher than the bleeding risk from a femoral venous puncture.
Is there another question? I saw a hand go up. Oh, there we go. Sorry.
Doctor, this is a little more general question, but I've always wondered, what do you do differently in integrative medicine, or do you call it interventional
So
cardiology?
yeah, so integrative cardiology integrates both like Eastern, Western modalities and treatments, supplements, and will kind of factor in holistic approaches. What I do is interventional
That's what I meant.
cardiology,
Yeah.
which is a procedurally oriented cardiologist, one who does stents, one who does valve replacements, one who does that. All structural cardiologists are interventional cardiologists by trade, but it's an added training on top to add valves to coronary stents and other interventional techniques.
Question there, just general. How many of you are patients of Dr. Panguluri? Very nice, very nice. And how many of you are heart patients? And the rest of you must be caregivers. All right, good. That's awesome. That's awesome. That's awesome. So are there any more questions from over on the Zoom?
Nothing on my side, Bill.
Any more questions here? You have a chance. Would you, since we're a little bit early, would you open it up at all for general questions or talk about TAVR a little bit?
Yeah, or I can even talk to you guys about the coming therapies that are coming up.
That
Like
would
you
be
said.
wonderful.
Yeah.
Wonderful.
So we do the MitraClip here at Eisenhower right now. The other therapies that are out there, there's another mitral valve repair technology that's out there. It's called the Edwards Pascal valve. And it's a similar device to the MitraClip. It actually came out, they were studying it at the same time that the MitraClip came out, but the MitraClip has been out about 5-6 years longer than the Pascal valve. Technically, they are very similar procedures. They look identical. The valve repair is just a different type of clip. I haven't found that one is superior to the other. They both work very well. But if you hear about another minimally invasive approach, it's called the Pascal clip as opposed to the mitral clip. They work similarly from what I can see based on the data, but there's never been a head-to-head trial looking at the Pascal clip versus a MitraClip. It's always just been Pascal versus surgery or MitraClip versus surgery, which is considered the gold standard. So that's one therapy that's still out there for mitral valve repair. As we talked about, there are trials that are looking at mitral valve replacement. And though they sound very promising at first, there is some concerns about replacing a mitral valve as opposed to repairing a mitral valve. If we go back to what the mitral valve looks like, the valve is attached to the side of the heart, but there's also little cords that come off the leaflet tips, and they're attached to the actual heart muscle itself. Now, when you replace a heart valve, you cut all those cords. You have to cut everything to put in a new surgical valve. Or if you replace it, whether you go up through the leg, you're cutting all those cables that are holding the heart in some position, in some morphology. So when you cut those cables or cut the cables that are attached to the valve, you worry that the heart itself is going to change its conformation a little bit. Now, will that affect long-term function of the heart? There's always some concern that if you get some dysynchrony with the heart, you could cause some weakness in the heart. So that's why we don't really like to do valve replacements unless we really have no other choice. When it comes to a TAVR or a transcatheter aortic valve replacement, the aortic valve fortunately does not have any other attachments to the heart. There's no cables that run from the valve into the heart. So replacing that valve really doesn't change the conformation or the size or the shape of the heart itself. So when it comes to the mitral valve, it's a little bit more complex valve anatomy than it is with just a aortic valve. I say just an aortic valve, but there's slightly different anatomical consideration. So though we're looking at these mitral valve replacements, I don't think the mitral clip or the Pascal clip are going anywhere. Because we also know based on surgical data, people who can get a mitral valve repair do much better than people who get a mitral valve replacement. partially because the valve breaks down, partially because we are changing the conformation of the heart by replacing a valve that's attached to the heart in more than one point. So we always want to be a little cautious when we go to mitral valve replacements. Now, when it comes to valve disease in general, again, we don't rush to do any of these procedures because, again, every procedure carries with itself some small risk. And two, valve replacements and even valve repairs, we expect there's a shelf life. There's only a certain amount of time this will work before they start degenerate or start leaking around or developing problems. So we want to get as much time out of your native valve as we possibly can without it causing any problems. So if you're not having any symptoms, your heart's not under any stress, you can have severe mitral valve disease. You can have severe aortic valve disease or other valve diseases. And the recommendation is not to intervene too early. Now, if you're 90 years old, maybe we should just intervene early. But if you're 60 years old, 70 years old, if you can get 5, 6, 7 more years, then that's 5 or 6, 7 more years later on in life that you may not need to worry about having a redo operation or a redo procedure done. So when it comes to valve disease, when we go back to the indications, symptoms are the key, or heart dysfunction is the key. Now, the valve replacements are coming. Those will probably be available in the next 5 or 10 years. We're looking at to try to get the transcatheter mitral valve replacements rather than repairs. When they do become available, guarantee Eisenhower will be one of the few sites. We'll start doing them here as soon as they become available. The techniques and the skills are very similar to what it takes to do a MitraClip. It's just getting the approval and studying the valve enough to make sure it's safe and effective. As you said, 80,000 people were studied for the MitraClips. It took about 30,000 people before it even got released to the public. Now over 150,000 people have been treated with it, and we're getting more and more data. And that's what's improving the recommendations, moving from a 2B to a 2A. As we see it be more and more effective, we'll probably lower the threshold for intervention and lower the threshold for proceeding with it.
Are there more questions? Please.
Dr. Panguluri,
Yes.
would you feel comfortable?
Okay, I just wanted to ask if you would feel comfortable if I would mention what you did with my neighbor without names.
That's fine. Yeah, that should be okay.
Yeah, just because I think it was just fantastic. My neighbor comes half the year from Texas in here. He had just arrived and he plays tennis every day. So he couldn't get, he tried to like lean over for the ball. He could barely bend over, which is not him. He tried to run. He couldn't run. He was just in, I didn't want to say how old he was yet. And anyway, a friend of his said, you have to have your heart checked. I think it's something like that. He said, but anyway, he was going to get an appointment in about a month. And John says, gosh, you're not doing good, Bob. You better see if you can get in sooner. Let me call Dr. Panguluri and see if he can get you in. Well, this was right before Christmas. He got him in the very next day that he called him. He ended up, I think, having, was it his mitral or was it his aortic?
Aortic valve.
The aortic. Okay, so he ended up having the aortic valve done, I think, like the day before Christmas. It was right at Christmas. But I mean, we're talking within 2 or 3 days, he had this done. And he was so happy, of course, and his wife was really happy because he was like a different person. But the point was he was 92. Also, he could play tennis again, of course. And I asked him, when did he, when could he play tennis again? And I think this was a Monday that I asked him. He says, oh, I'll be there I can go on Thursday, which like less than a week, this whole thing. And he could barely, so anyway, this man did it, Dr. Panguluri, and we thank you, everybody.
I gotta say, that brings up an important point. There is no age limit on these procedures. These procedures were designed for people more elderly. And the oldest we've done some valve interventions on, the oldest I did was a 106-year-old. And he went home the same day because he didn't want to waste a day of his life. And he said, I'm going home. And he went home the same day after these valve procedures. So we don't like to use an age cutoff for these procedures at all.
I have a question. It's my understanding that the aortic valve is more round.
Yes.
And the mitral valve has a more unusual shape. And that's one of the reasons it's taken a while to replace the whole mitral valve with a catheter. Is that correct? Or?
That's exactly correct. And I said the mitral valve attaches in 4 or 5 different points to the heart. The aortic valve attaches just in that round circle area. So the multiple connections also make it a little more challenging. And the anatomy, like I said, it's more of like a horse saddle than it is a round circle annulus.
One question I have is if you have a athlete, a runner,
Mhm.
whose whole heart is much larger than normal, does that cause him to die sooner? I mean, you say you're talking about pulling the heart apart?
Yeah. So athlete hearts is a known phenomenon. People who do run, who are quite fit, will develop thickening of the heart and will actually develop what looks like a cardiomyopathy or a weakened heart. But in fact, those are actually not dangerous compared to the other type of cardiomyopathy, not due to exercise. The treatment of that is to have the person not exercise for 6 months and reevaluate the heart. And usually the heart goes back to completely normal. But we know there's no long-term sequelae from the athlete heart, as opposed to the other type of heart, which if you don't do exercise for 6 months, it won't get any better. It'll stay weak.
Just one question. The best diagnostic tool would be a full echocardiogram. Is that correct?
So that's actually a very good question. Now, there's 2 modalities to really evaluate the mitral valve. 3 if you consider an invasive approach. The standard echocardiogram is a very good screening test. And that's done with you awake, laying on a table with some gel applied on your chest. That's under real world conditions when your blood pressure is elevated. We can really see the mitral valve regurgitation on it. There's a handful of people, though, that those echocardiograms, we don't get to see the mitral valve clearly enough, whether that's because of breast tissue, bones, whether it's due to the lungs getting in the way, stomach sometimes getting in the way, that we just can't acquire the images. And we may really underestimate the true severity of mitral valve regurgitation. In those individuals, sometimes the best way to assess for mitral valve regurgitation is if it's questionable or you keep ending up in the hospital with heart failure and we don't have an explanation, is to do what's called a transesophageal echocardiogram. That's where you swallow a camera into your esophagus. The same echocardiogram probe we use to look at the heart from the outside, you actually put it in your esophagus, and your esophagus happens to run right behind your heart. So it takes away all of the obstructions, no lung tissue, no bones, nothing there to really kind of interfere. And what you can do is then get a much clearer picture of the mitral valve. And anytime we do a mitral valve intervention, whether it's surgery or mitral valve repair with the MitraClip or Pascal, we always recommend we do the transesophageal cardiogram because that really helps us identify the mechanism of mitral valve disease. Is it due to the heart getting enlarged? Is it due to a primary problem in the valve? So the combination of both of those tests usually can help identify mitral valve disease. Now, rarely we can do indirect ways of looking at mitral valve regurgitations as well. If you're getting a heart catheterization, which is an invasive procedure, and you have a catheter in the heart, sometimes you can get a suggestion that you have mitral valve disease just based on how the pressures are acting inside of your heart. So a doctor is doing it, even if you didn't know you had mitral valve disease, based on how your pressure tracings look, can raise a suspicion. It won't diagnose it, but it can raise a suspicion that maybe we need to look more carefully at the valve. So that's another way of really kind of making the diagnosis. Now, physical exam findings, people who have mitral valve regurgitation almost always have a heart murmur. Now, it usually starts off as a quiet murmur. Over time, it'll get larger and louder. And if it gets really severe and the valve's not working at all, sometimes the murmur starts getting quieter again. So that's just because the murmur is going away isn't always a good sign. It means that if the valve is leaking so much, you're not hearing noise anymore. So normally you hear a heart murmur when blood like tumbles or rumbles across the valve. But if there's no valve or the valve is leaking quite a bit, you may not hear a murmur anymore. So if you had a heart murmur, it got louder and it's getting louder, and all of a sudden it starts getting quieter, you worry that the valve actually has gotten worse, not that the valve has gotten better, unless you've had a valve repair or replacement.
Thank you. Is it my understanding that somebody, you were talking about the enlarged heart, somebody that's been very athletic all their life and was diagnosed with an enlarged heart, say in their 40s or 50s, and
Mhm.
that happened to me actually. But he told me that not to worry, but the only thing he worried about as you got older, because of the heart being enlarged, that maybe the arteries are not as clear as they used to be, and not getting enough blood there. But what you just said was that it will come back.
Yeah, if
It's
you
a
don't,
muscle. It's a muscle, right?
it's a muscle. So if you don't use it, it'll shrink
Right.
and kind of
Just like
return
the
back.
muscles in your body, when you don't use them, they return to their normal size. Is that correct?
That's right. If that's what you had with an athlete's heart, that's what happened. Now, if you have a thickened heart due to a genetic condition, what's called a hypertrophic cardiomyopathy, then your heart will be thick and exercise will make it thicker, but stopping exercise won't necessarily shrink the heart down.
Right.
So most of the time people have athlete's hearts, they'll have them in their 20s, 30s, maybe up to their 40s. But by the time you reach 50 or 60, most people just naturally cut back due to other reasons, and their heart will usually return back to a normal size, assuming there's no other pathology underneath.
Okay, thank you.
Question? When a person gets a MitraClip, are they recommended to go to cardiac rehab?
They are recommended cardiac rehab. Any valve intervention, we recommend cardiac rehab, which is a 6 to 12 week supervised exercise program. It's done out of our clinic 3 times a week, about an hour to 2, where the nurses will monitor your exercise, build it up as you can progress through the program. There'll be a nutritional component talking about what to eat, what not to eat. And it's recommended for all valve replacements. It's also recommended if anyone's ever had a heart attack, if they're being hospitalized frequently in the hospital due to heart failure, or even if they've had heart stents put in. We recommend the program. Now, it may seem a little tedious, it may seem a little involved, but people who graduate from cardiac rehab, we do know they do better in the long run than people who don't complete cardiac rehab.
I have a wonderful story about cardiac rehab. It relates to my father, who at 93 years old had open heart surgery back in Illinois. And he went to cardiac rehab and he was doing quite well at it. And I went and visited him. This is about within a month, I think, after he had started rehab. And I said, "Hey, Dad, how do you like cardiac rehab?" And he says, "I really like it." And I said, "Whoa, that's interesting." Well, I went to cardiac rehab with him the next day. And there's these 2 really cute nurses that are just fawning all over him. And no wonder he liked cardiac rehab so much. So.
Your father have to get married?
John, that's not nice. My father did, after his open heart surgery, had a bypass after a massive heart attack. His ejection fraction was down in the mid to low 30s, but he lived to 106 and a half years old. And when he was 99 years old, he married an 80-year-old lady. So if we talk about hope and encouragement here, this is the whole deal right there, okay?
He always he would say, "I had to marry her."
John. Isn't it? John here, this dirty old man right here asked me if my father had to get married. Isn't that something? I mean, we're good friends, otherwise I wouldn't say that. So are there any more questions for Dr. Panguluri? I know he's gonna go home to his new wife and, anyway, so this has been terrific. We really thank you very, very much. And wow,
And thank you guys for your time.
been a great thing, and we hope you'll come back again in the future sometime. You're doing some amazing work here at the hospital. He does these TAVR things too. I know there's 2 other doctors that are in this group that do the TAVRs. And they do them primarily on Wednesday. And there's, I guess, about 5 quite often on Wednesdays that are being done between the 3 of you. And you do 2 or 3 on a day sometimes, right?
Yes.
That's pretty amazing. When you think about it, it's really pretty awesome. So
Yeah, we call it MitraClip Mondays, TAVR Wednesdays, and I do stents on Fridays.
do stents on
Yeah,
Fridays, right? Where do you see patients?
Tuesdays and Thursdays.
Thursday, okay. Well, that's great. Well, thank you so much for coming. It's been really a delight. Before everybody takes off out of here, and he will stay around a few minutes if you like, but we're going to close this session out on Zoom, but I want to tell you a couple of things while the people are on Zoom. This lecture will be on Eisenhower's YouTube channel. You can go on eisenhower.health.org and find that on there. It'll be on there in about 2 weeks. And all of the lectures that we have had during this last excuse me, 8 months, will be on that particular channel. They're very helpful as you want, if you want to go back and review this, for sure. We are also interested in here, then we visit patients in 2 hospitals, Eisenhower and also Desert Regional in Palm Springs. And we just started there again after COVID now, about 3 weeks ago or so. And we've been visiting patients there. And there are 3 of us in here in the room doing that over at Desert. So we're looking for visitors. If you are a heart patient and you want to do something super rewarding, become a volunteer in the hospital and volunteer with us in Mended Hearts, we'd love to have you. It's really probably the most rewarding thing. Talk to any one of these people in here that have a white jacket on, besides him. And you'll find out it's terrifically rewarding. It really is. It's giving back in a manner that you can't believe. So we go around and see all the kind of heart patients, not just heart bypasses or anything like that, anything, heart failure, AFibers or whatever it might be. So we try to help them out. We also have a quarterly newsletter that we publish, and if you would like that, and if you want to get that copy of that, there are some over on the table over here. And we send them out quarterly by email. For those folks that are on Zoom, if you want to call me at 760-772-1461, I'd be happy to send that thing to you. We'll get you on the email list. And our email deliverer, David, back here in the room, he'll take care of that for everybody. So we're so glad you're here. Our next meeting will be on June 8th, right here in this room. And it's going to be, we're going to have 3 pharmacists going to come and talk to us about cardiac medicines. And you can ask all the questions you want about that medicine that messes with your stomach or whatever else. So please come here or on Zoom. We welcome you, and it'll be a terrific session for us. And for that session, Dick Freeman over here is going to moderate that for us, and we appreciate that, Dick. Thank you very much. So are there any questions before the doctor leaves here? Well, again, let's give him a really wonderful hand. Thank you very much. Thank you. Appreciate it.
Thank you guys again.
Thanks.